So I think we're going to start this lunchtime session. Welcome, everybody. It's really lovely to see you here. I hope you've managed to have some lunch. My name is Rachel Thompson. I work as an Admiral Nurse, a dementia specialist nurse, funded by the Lewy Body Society in the UK. And I support families affected by Lewy body dementia. However, today's session, I am absolutely honoured and delighted to be doing this session with Dr. Daniel Drubach, who we've only met very recently. So I'm going to give a little bit of a biography, if that's okay, and then really we're going to just listen to what you've got to share. So Dr. Daniel Drubach, MD, is Professor of Neurology at the Mayo Clinic in Rochester, Minnesota. He completed training in both psychiatry and neurology. I think we're getting a bit of feedback, aren't we? Is that okay? At the University of Maryland in Baltimore. Subsequently, he completed a fellowship in neurorehabilitation at Kernan Rehabilitation Hospital. He was head of the Traumatic Brain Injury Rehabilitation Program and co-director of the Coma Emergency Program at the University of Maryland for several years. He then went on to join the Behavioral Neurology Division at Mayo Clinic, where he's worked for the past 20 years. His main interest and expertise is in various dementias, including neurodegenerative disorders, autoimmune and paraneoplastic processes, and many others, I suspect. But he's got a special interest in dementia, and particularly dementia with Lewy bodies. So he's still active in the training of medical students as well as residents and fellows. So hopefully that's done you justice. I hope that's summed up a little bit of your career. So, Daniel, the reason we're here today, and I wanted actually just to highlight a piece of work that Daniel wrote and I had the privilege to read, but we're here today because you have a diagnosis of dementia with Lewy bodies. So, if people who haven't read this, I would really urge you to. It's called Twilight and Me, a soliloquy, and it was published in the American Academy of Neurology last year, I think. And it provides a unique and very special insight into your experience. But firstly, I'd just really like to ask you just to share a little bit about how it's been since you got your diagnosis.
Well, first of all, I'm very thankful to Dr. Thomas and to Rachel. I'm very honored to be here. I'm very honored to be here. This is going to be mostly a conversation. I'm just going to make a few comments and then we can open up for questions. One of the questions I get asked frequently as a patient, and when did I start having symptoms, and what were those symptoms? And I do remember one time, and this is a true story, where I was in an office with a colleague, discussing a patient, and the phone rang, and my colleague, who's very dutiful, and she just took the call and continued speaking and speaking. I was kind of bored, and you know, and then I saw what I at that time called a vision, you know, it was a hallucination, but I called it a vision at the time. It was basically some kind of creature. There was a little bit of a dragonfly and a little bit of a ballerina, and that creature was spinning. And I looked at my colleague. He looked back, and clearly he couldn't see it, which is one of the things of hallucinations, that they're probably only to you. You know, and the creature just kind of spun. He kept spinning, went into the wall. That was when, you know, I was pretty much spellbound. I was very, affected by that. And shortly afterwards, I began having other hallucinations. Again, this is about 4 years ago. My wife keeps a diary of them. And I was walking through a forest, and which I walk very frequently, and I saw a dog on my side, and the dog made wires, and then I saw this lady coming with a baby carriage, and she was coming up from one side, and she stepped on the dog and killed it, I guess, or she's thrown into the ground. Those and other hallucinations, and since that time I have had many, and I think that was kind of the beginning, noticeable of my disease. And after that time, I began having many different hallucinations. Hallucinations have been my and everything, cows in the bathroom. Some of my patients too, I was describing. And it's interesting when you see patients, have them describe a hallucination. I'm not sure if there's any, at least it's it's interesting. I don't know whether it has any clinical having. So I realized, with a little of a shock, that this is something that's abnormal, and I, since having seen patients with Lewy body disease for many, many years, many decades, at least 2 decades, I realized that it was DLB. And that was quite an interesting realization. And then I kind of remember what I felt with the diagnosis of DLB, what I felt. And I was angry because all of a sudden, but I was very sad, it was very, and this kind of sadness that comes from knowing that you won't be able to do certain things. And I kind of knew at that time that my life was going to change. And and that did bring this sadness. I also was angry at fate, and I shouldn't have been, but I was angry at fate that kind of had given that to me. And I am very interested in fate and how this happened. And I also began, fear the future, because being a behavioral neurologist, seeing Lewy body disease, you see it all, and you see what happens with many patients, and some. I was concerned about progression, and there was progression, and that's, I felt like that. But I also, as I was looking at that and I was feeling, I became amazed at the symptoms. I thought, this is so weird. And then one of the ones that I thought was most bothersome and most fascinating is what's called sense of presence. And then it's difficult to describe if you don't feel it. And that's where it helps being a physician and being a thing. And in sense of presence, I walk, in order to unsuccessfully decrease my weight, I walk miles a day, and there's always this presence that walks by me. And it's difficult to it's not a pleasant sensation, at least not, again, with time, because you see it's always there. You look, and and there's also and there's also called a sense of absence, that you feel there is something missing in the room, and those are fascinating symptoms. And if I say a neurologist and psychiatrist, they're hard to explain what network is affected to have a sensation that there's somebody next to you. It's so strange. When you have a stroke, you can correlate the stroke with the deficit that you're left with, but With this, which network is activated, which makes me think that what this is an amazing, and therefore I changed a little bit from being sad to being curious, and I'm very, very curious, and there's so many things in Lewy body disease which are difficult to explain from a neurobiological sense. It's very, very difficult. It's not so difficult. I mean, I don't want to take away from it, but in Alzheimer's, you can correlate hippocampal lesions or hippocampal atrophy with memory loss. And Lewy body disease, they're very, very, very strange. It's always one of the things that Lewy body disease gave me, and I think really gave me the ability to really jump into another reality, because when you are in that state, where you're in a forest and everything looks, it's like you're in a different reality. Either another reality is provided or that's very, very interesting to feel all this sensation. Yeah, go ahead.
Can I ask you, you spoke about coming from a position of knowing, looking after patients with this condition.
Right.
And then now you are experiencing the symptoms you've seen in patients before, and that different perspective. How has that changed when you look back? How has that changed your view on understanding what people are experiencing?
It is difficult to explain, but it's very, very different for a patient to tell you a hallucination than to feel the hallucination yourself. And I think it's good to discuss it with the patient. It's a very, very different perspective to describe what somebody tells them and what you. And so with everything, and then they say, well, you explain to somebody about the person. There's a person walking next to you all the time, and it's not the same as feeling it, because it's not so simple, and that's one of the things in neurology and in language theory, which I'm very interested in, is that there are some words that you cannot define. Love. I mean, you could speak a lot about love, but to really experience it, you have to have had it before. You have to have been a sense. And this, I think, I should see the same thing as that is.
So I've just thought of this question, so I haven't prepared you. But if you were to wind the clock back to when you were a physician looking after people and you wanted to find out how it felt for your patients, what questions might you ask, or what would you change?
I would ask more about symptoms that are frightening, like hallucinations become very frightening, and how it's they're dealing with this different reality. I mean, if you're kind of a twilight zone, and but you are dealing with a different reality.
So one of the things that struck me from talking to you is this balance between the initial fear and then shifting that to a sense of hope.
I very much has really handled hope. I think hope is the most important. It's a beautifully expensive feature that cannot be spoken good about it. It's another word that you can really describe what is hope. But yeah, I changed more from hope that the things would stay the same or they wouldn't. But I do, continue to have fear that I won't be able to attend my son's wedding. He's only 18, so hopefully I doesn't do that. But that's
So for people who are listening, both perhaps people who are directly affected, but also for clinicians, have you got any messages that you'd like to share?
I think it's important to do that, to see the beauty in the ugliness, in the, because there's a lot of, people don't believe it when I say there is a lot of beauty to some of the shapes. It's like there's another universe. You walk and you see a lot of forest, and then you look a little bit farther, and there's, instead of a forest, it's a flamenco. I'm very much into flamenco. Flamenco dancer. It's almost like there is a the author of the Little Prince, one I'm sure people have read, talks about that. This idea of you see a pile of rocks, and you see a forest, and you see a cathedral.
So something about inviting people to understand your reality, what's happening to you. What has helped you? What helps you now in terms of managing your symptoms? Well,
one of the things about ILBD, which is another fascinating thing, and it's very difficult to explain, are these fluctuations or unpredictability. That's a human condition where everything's unpredictable. But in Lewy bodies, it's very, very obvious, and it's very persuasive. And so you can be doing very well for weeks, or for days, or for hours, and certainly my family notices it. So I don't know how to prolong those moments of respite, from the ataxia and from the hallucinations and from the
And you have a beautiful way of writing, and my feeling is that writing helps you process
tremendously. Yes, writing makes me understand it better, and I think that's something that's and what I found. Again, the writing is very, very important. Exercise is very important. I like many people with DLB take cholinesterase inhibitors such as Aricept or Rivastin and things like that. And I think walking, and I used to tell my patients, walk 3 miles a day. I think it's extremely important to walk. It's not only it's not a psychological well-being from being outside. It's not just that. I think it really has almost like a pharmacological effect.
So the benefit of exercise, being outdoors. You're also a skilled guitar player. You're also a very good guitar player.
I'm a guitar player. And that has one of the things that's been affected, and Lewy body disease has given me something, giving me a different reality. It's given me, but it has taken away some things, and the guitar it's one of it. I lived many, many years in Rochester, Minnesota, and I was the best guitarist in that city because I was the only one. So I assume, with the movement, with the Parkinsonism, it gets a little bit affected. But it's like everything, it's been doing very well in the last couple of months. And we'll see what happens with time.
So, before we open up to questions, I'm hoping that people may have some questions for you. But any final messages, anything you would like people to go away with having listened to you?
Sure. One of the things is how much, as clinicians here, how much you reveal to the patient. I'm a big believer of Spinoza. Spinoza is a philosopher from 12th century, I believe, who said once you tell a patient they're dying, once you give them a date, you say, well, 4 to 5 years, the person starts dying, literally. And I always caution my fellows. I have a wonderful, wonderful set of fellows. Many are here today. Be careful what you tell the patient. Be careful, what to tell the patient, because really don't know. And I want to stress to the patient, and again, I have a little bit criticized for this, that you don't want to come up with a diagnosis, but you don't want to become the disease. You spend so much time looking for a diagnosis, and I myself, I should participate in trials. I don't, because, I don't want to lose time. And I think when you're diagnosed with this, you have to live with a sense of urgency. You just have to, so, do the usual things of hallucinations that were mentioned downstairs, and lights, more lights, but doing as much as possible. Even if you don't spend the guitar, do it. Because I think I'm a big believer in task, as some people call it, task-oriented brain plasticity. That means when you ask the brain something, the brain tries to do it, to give you enough neurons to do it. Always not very successful, but doing, and a purpose. The thing is, the patients do find new hobbies. Being told you have a dementia is our society does not totally like demented patients. It's so that I think is very important to give hope and to do as much as possible, to have a purpose. And I do think it's very, very important to have a team, that includes medical care, nurse practitioner, nurse, and meet on a basis to address. As this is a progressive disease, but again, it has fluctuations, and take care of, enjoy those fluctuations. And unfortunately, it's not, you never know when those fluctuations are going to happen, but we don't understand why they happen. I mean, there's no, and so once more, in everything in LBD or DLV, or even the names, there is difficult to, it's fascinating. As a neuroscientist, it's fascinating for somebody to, and ask, I was talking to one of the beautiful person, Dr. Brad Bovee, who I know, and asking, do you have the symptom? Do the patients tell you about it? And he says, almost everyone. And, so you have to ask. It would surprise me, because I thought it was only me. But,
So thank you for your profound honesty and humility, coming from both perspectives. I just was going to the last line in your soliloquy, which has really moved me, was a person walks in life on a very narrow bridge. The most important thing is not to be afraid, which is. So I'm going to invite the audience, really, if there's anybody. There's one here, and then the lady in the green card. And so, Chris, do you want to? You might need a. Can you stand up? There's a mic there, or do you want to?
Thank you very much. It was fascinating listening to your talk. I'm a person living with Lewy body dementia, having initially been diagnosed with vascular dementia when I was 60 years old. I've got two questions I'd like to ask you. You mentioned hope, and I think that is so important for all of us. And my experience, having had two dementia diagnoses, were very negative experiences. And I was told, you have dementia, go and get your affairs in order. And I know that there have been people who've had a diagnosis in that way and have committed suicide because they're not given any hope. And my plea to people giving diagnosis of dementia is maybe say there are certain things you won't be able to do. However, there will still be many things that you can still do to give us that hope. And having been on both sides of the fence, as a physician and a person living with DLB, are you able to explain to your professional colleagues more of an insight as to hallucinations and things like that? Thank you.
You know, one of my difficulties is hearing. And
So Chris was saying, having been a physician, and Chris has a diagnosis, but had a very negative experience. But she was saying, as a physician, how do you think you can give hope when somebody's given a diagnosis?
First of all, it would be not a good thing to, I am losing some words. We don't know what's going to happen without us. I don't know what's going to happen this next day. So I think, as a group, Lewy body disease patients don't do well, but individually, many do very well. And I think it is
So I think we're being told we have to wind up. Thank you. I'm so sorry, but maybe, Daniel, if anybody's got a question for you, are you okay to talk
Sure.
to people outside? Is that okay? Yeah. I'm very sorry to cut things short. I was so enthralled, but I'd like to give, if everybody could give Daniel a big round of applause.
Okay. Thank you so much.